Imagine a bustling emergency room. A patient arrives, their body radiating heat, every breath a struggle. There's an unspoken pressure in the air, a silent alarm ringing.
Mm-hmm.
In these critical, often life-or-death moments, outcomes can pivot on a dime. The difference between a full recovery and, well, a devastating loss often hinges on rapid, precise action, a true mastery of the situation.
It's a moment that crystallizes everything medical professionals train for. It's not just about treating a symptom. It's a high-stakes race against a rapidly escalating threat, demanding both honed intuition and cutting-edge science.
Exactly. And that's our mission today. A deep dive into mastering the approach to the acutely ill-infected febrile patient. We're going beyond the basics, trying to understand how elite professionals navigate these urgent cases.
Right.
From that crucial first glance to leveraging revolutionary tools like genomics. We're talking about achieving a level of insight that truly equips you, the listener, to understand the gravity and precision of this medical challenge.
Yeah, and we've distilled essential knowledge from robust medical guidelines. We're pulling out not just the protocols, but also those, surprising facts and critical nuances that make all the difference in real-world scenarios.
Kind of a shortcut to being truly well-informed on a topic where seconds really, really count.
Absolutely.
Okay, let's jump right into those critical first moments. When a patient arrives with acute fever, there's an immediate, almost instinctual assessment happening even before any formal diagnostics begin. Think of it as recognizing the emergency of the perceptive physician's eye.
That's exactly right.
Right.
Before a single lab test is ordered, before a detailed history is taken, a clinician's immediate assessment of a patient's general appearance provide invaluable information. This subjective sense, that feeling that a patient is septic or toxic, it often proves incredibly accurate.
Right.
It's a culmination of years of experience and just sharp observation.
So it's more than just a gut feeling. It's the highly trained intuition. And one specific visible sign that our sources highlight is agitation or anxiety in a febrile patient. This isn't just discomfort. It's explicitly called out as a harbinger of critical illness.
A real red flag.
It's a visual cue telling you this patient needs immediate, serious attention.
Absolutely. And here's where it gets, well, truly counterintuitive sometimes. While fever is typically present in an infected patient, critically ill patients can actually be hypothermic.
Lower temperature.
Yeah, their body temperature is abnormally low. And this isn't a good sign. It carries a high risk of organ failure and mortality. Yet, surprisingly, some studies have shown that 30-day mortality has actually been shown to decrease with increasing temperature at presentation.
Wow, that's unexpected.
It tells us the body's response to severe infection is incredibly complex. Sometimes a robust fever can actually indicate a stronger and, a fighting immune response.
That's fascinating, right? It really underscores that you can't rely on just one vital sign in isolation. So after this perceptive glance, what's the immediate hands-on action? What happens next?
The absolute priority is the rapid measurement of core vital signs: blood pressure, heart rate, respiratory rate, and oxygen saturation. These immediately help determine the degree of hemodynamic and metabolic compromise.
Basically how stable they are.
Exactly. How well their blood circulation and their body's energy production systems are functioning. Concurrently, there's an immediate evaluation of the patient's airway to rule out obstruction, especially if there's suspicion of an invasive infection in the throat or mouth. Maintaining an open airway is fundamental. Rule 1, #CARDEAB. The power of a thorough history unpacking the clues.
Okay, so once those initial life-saving assessments are underway, the next critical step is getting a thorough patient history. Our sources emphasize that presenting symptoms are often maddeningly nonspecific. A cough could be a cold or it could be something much more sinister.
Very true.
So a detailed history is paramount to unearth the hidden clues.
Indeed. It requires precise and detailed questions. Things like the onset of symptoms, their duration, any changes in severity over time, and the rate of progression. You're building a timeline, understanding the trajectory of the illness.
Okay.
But even more critically, we delve into what we call host factors. These are the patient's individual characteristics that significantly increase their risk of infection or predispose them to a more fulminant course.
Fulminant meaning really fast and severe.
Exactly. Sudden, severe, and rapid progression.
Okay, here's where it gets really impactful for understanding patient vulnerability. Let's unpack these host factors because they seem crucial. We're talking about extremes of age, right? The very young, the very old.
Yep. Their immune responses might not be as robust. Then there are a range of existing medical conditions. Lack of splenic function, for one.
The spleen. that fights certain bacteria.
Vital for it.
Yeah.
Especially encapsulated bacteria, those with a protective outer coating. Without a spleen, individuals are highly susceptible.
Makes sense. What else?
Alcoholism with significant liver disease that compromises immune defenses and the liver's filtering ability. 4B drug use provides a direct route for pathogens. HIV infection obviously devastates the immune system.
Right.
Diabetes impairs immune function, causes microvascular damage. Malignancy and chemotherapy severely suppress the immune system. Morbid obesity is linked to chronic inflammation and impaired immunity. And organ transplantation.
Where they're trying to suppress the immune system.
Exactly. Immunosuppressive drugs are used to prevent rejection, but they leave the patient incredibly vulnerable. Each of these factors doesn't just make a patient sick, it predisposes them to specific infections or to a far more aggressive, often deadly progression than a healthy individual might experience.
So knowing these factors can immediately narrow down the list of potential bugs or signal the need for really aggressive therapy.
Absolutely. It changes your whole approach.
Beyond the host, the history also needs to identify the nidus, or the source of the infection. What kind of questions are we asking here? Playing detective.
Pretty much. We're asking about anything that could be a point of entry or a starting ground for infection. This includes recent upper respiratory tract infections, influenza, or varicella chickenpox, which can sometimes precede bacterial superinfections.
Well,
We look for prior trauma, any disruption of cutaneous barriers like lacerations, burns, recent surgery, body piercing, or decubitus.
bed sores.
Right, bed sores. And importantly, the presence of foreign bodies or prosthetic devices. They can act as permanent sites for bacterial colonization and infection.
So a surgical mesh, a joint replacement, even a pacemaker could be a hidden source of trouble. And then there are the epidemiological clues connecting the dots that might lead to diagnoses you wouldn't otherwise consider.
Absolutely. This is where the physician truly acts like a detective. Questions about recent travel are critical, especially to areas where diseases like malaria or dengue are endemic. Presence during natural disasters, like a hurricane or tsunami, can expose people to contaminated water or unique environmental pathogens. Contact with pets or other animals, or activities that might result in tick or mosquito exposure.
Like hiking or camping.
Exactly. That can uncover vector-borne illnesses that are often missed, like Lyme disease or babesiosis if they've been in a tick-infested area.
And we can't forget the broader context of a patient's life, right?
Precisely. A thorough review of systems needs to be conducted. This includes asking about recent dietary intake, medication use, especially immunosuppressants or recent antibiotics, social or occupational contact with ill individuals, their vaccination history, recent sexual contacts, and for women, their menstrual history. Each of these can provide vital clues.
And pregnancy, you mentioned that as a host factor. It's a category all its own.
Yes. Pregnancy, surprisingly perhaps, can significantly increase the risk and severity of certain illnesses like influenza or COVID-19. This is due to physiological changes in the mother's immune system. And even more critically, some infections during pregnancy, such as Listeria or Zika virus, pose significant morbidity risks directly to the fetus. So rapid identification and treatment are paramount for both mother and child.
Wow.
And as part of the systematic review, we always check for any neurologic signs or changes in sensorium, a person's level of consciousness or awareness, as well as rashes, skin lesions, or focal pain or tenderness. These can be direct indicators of severe infection, either systemic or localized. ###TANC. The focused physical examination, what to look for.
All right, once we have that detailed history, the physical examination takes center stage. Our sources emphasize it must be complete, but with special attention to several areas that are sometimes, well, given short shrift in routine exams.
Yes, the focus here is not just on the obvious. It includes reassessing the patient's general appearance, but then delving into a detailed examination of the skin, soft tissue, and neurological systems. These areas often hold the most visible, yet sometimes subtle, clues to severe infection.
I can imagine how critical a thorough skin exam would be. It sounds like the skin can tell you so much.
It truly can. A thorough skin exam can actually yield an immediate etiologic diagnosis in some cases. For example, petechial rashes, those tiny pinpoint red or purple spots caused by bleeding under the skin, they're typically seen with life-threatening conditions like meningococemia or Rocky Mountain spotted fever.
Okay, those tiny dots are a big deal.
A very big deal. And diffuse erythroderma, which is a generalized redness and scaling of the skin, almost like a sunburn, that's a hallmark of toxic shock syndrome. These aren't just rashes, they're alarm bells indicating systemic issues that require immediate attention.
So a doctor looking at skin isn't just looking for a rash, but a very specific pattern that points to a specific urgent diagnosis.
Yeah.
What about clues from the soft tissue and muscles?
Yeah, on soft tissue and muscle examination, you're looking for areas of erythema or redness, maybe a dusky discoloration, swelling, or edema, and tenderness when you press on it. These can all indicate underlying rapidly destructive infections like necrotizing fasciitis, myositis, or myonocrosis.
Things eating away at the tissue deep down.
Exactly. And these conditions are often surgical emergencies.
And finally, the neurologic assessment. I imagine changes there would be particularly alarming.
Absolutely. The neurologic examination must include a very careful assessment of mental status. Any signs of early encephalopathy, any confusion, delirium, or lethargy are major warning signs. Physicians also specifically search for nuchal rigidity or neck stiffness, which indicates meningeal irritation.
Like with meningitis.
Right. Or any focal neurologic findings like weakness in just one limb, which could point to an intracranial infection like a brain abscess. These signs require immediate action because brain function is at stake.
All right, so we've done our rapid initial assessment, we've taken a thorough history, and performed a focused physical exam. Now we move into the diagnostic imperative, getting to the core quickly. This is where lab tests and imaging come in, but there's a crucial sequence to it, a race against the clock to identify the enemy.
Precisely. After that quick clinical assessment, the core idea here is that diagnostic material must be obtained rapidly. And crucially, before antibiotics are administered. This is paramount.
Why before?
To ensure accurate identification of the pathogen, antibiotics can suppress its growth, making it harder or impossible to culture later. You need that clean sample first.
So we're talking about blood samples first, right?
All right.
What are the key things clinicians are looking for in the blood?
Yes. Blood is the initial focus. Specific blood tests need to be drawn at the time an IV line is placed and, critically, before antibiotics are given. This includes multiple sets of blood cultures, especially important if you suspect something like acute endocarditis where bacteria are actively circulating.
Need to catch them in the act.
Exactly. We also look for a complete blood count with differential to see how the immune system's reacting. Serum electrolytes, blood urea nitrogen, and serum creatinine to check kidney function. Serum glucose for blood sugar. Liver function tests.
Whole panel.
A comprehensive panel, plus key markers like serum lactate, C-reactive protein, lactate dehydrogenase, and D-dimer. These can indicate severe inflammation, organ damage, or issues with blood clotting. It gives you a snapshot of the patient's systemic response and organ function.
And blood smears. Are they still relevant with all our advanced tech?
Absolutely. Blood smears retain a critical role, especially for patients at risk for severe parasitic diseases like malaria or babesiosis. They allow for immediate diagnosis and quantification of parasitemia.
The number of parasites in the blood.
Right, which is vital for guiding treatment. Blood smears can also be diagnostic in ehrlichiosis and anaplasmosis. And of course, in our current climate, testing a nasopharyngeal sample for possible COVID-19 may also be indicated right at this stage. #B, imaging and specialized procedures, precision diagnostics.
Now let's talk about imaging and specialized procedures, especially for those suspected brain infections. This is where the sequencing of actions becomes truly fascinating, almost like a medical thriller plot point.
Indeed. For patients with possible meningitis, the imperative is to draw cerebrospinal fluid, or CSF, before antibiotic therapy is initiated. This gives you the best chance of identifying the causative pathogen directly from the spinal fluid. But there's a crucial life-saving sequence here. If the patient has focal neurological findings, depressed mental status, or papilledema swelling of the optic nerve visible in the eye exam.
Signs of pressure in the head.
Exactly. If those signs are present, brain imaging must be performed prior to the lumbar puncture. This is to prevent brain herniation, a potentially fatal complication if you do an LP when intracranial pressure is high.
So it's a tightrope walk, get the diagnostic fluid, but don't cause harm, and the antibiotics. When do they fit in this complex sequence? It sounds tricky.
The timing is critical and, often counterintuitive for those outside of emergency medicine. Antibiotics should ideally be administered before imaging, but after blood for cultures has been drawn.
So blood cultures first, then antibiotics, then imaging if needed, then the LP.
That's the ideal sequence in that specific scenario. It ensures treatment isn't unduly delayed while waiting for a scan, but also that those initial blood samples aren't affected by the antibiotic. And remember, if CSF cultures happen to be negative, which can happen, blood cultures will often still provide the diagnosis in 50% to 70% of meningitis cases.
And we're moving beyond traditional cultures, right? Especially for speed.
Yeah.
Molecular tests.
Yes, this is where molecular diagnostic techniques are making a huge impact. For example, broad-range 16S RMA gene polymerase chain reaction testing PCR for bacterial meningitis pathogens is becoming increasingly important. These methods offer rapid diagnosis of life-threatening infections, sometimes in hours, allowing for quicker, more targeted treatment.
That's a game changer. What about other localized infections like abscesses? You mentioned those earlier.
For focal abscesses, immediate CT or MRI is necessary. This imaging is a crucial part of the evaluation for potential surgical intervention, as many abscesses require drainage to be cured.
Right, the source control idea.
Exactly, and it's important to stress again that other diagnostic procedures, like getting wound cultures, should not delay the initiation of treatment for more than mere minutes. The priority is always to start life-saving therapy as quickly as possible.
And once the immediate emergencies are addressed, the diagnostic journey continues.
It does. Once the emergent evaluation, diagnostic procedures, and appropriate surgical consultation are complete, then other important tests can be conducted. This includes appropriate radiography, maybe additional CT or MRI imaging, urinalysis, measurement of inflammatory markers like the erythrocyte sedimentation rate, C-reactive protein, and a form or procalcitonin, and maybe transthoracic or transesophageal echocardiography, especially if endocarditis is suspected. All of these contribute to a comprehensive diagnostic picture, allowing for fine-tuning of treatment as you get more information.
So we've identified the emergency, gathered our clues, rapidly collected diagnostics. Now we shift to the treatment foundation, principles of emergency management. Speed is obviously critical here, but what are the core principles guiding these decisions?
It absolutely is. The core idea in managing the acutely ill febrile patient is that empirical antibiotic therapy for presumed bacterial or fungal infection is critical and must be administered without undue delay. Every minute counts.
Empirical meaning.
Hmm.
Based on the best guess before you know for sure.
Precisely. You start broad-spectrum antibiotics before you have a definitive diagnosis, based on the clinical picture and what pathogens are most likely.
And this isn't happening in isolation, right? It's part of a bigger stabilization effort.
No, not at all. It's often a multi-pronged approach. You're simultaneously providing supportive care. This includes parallel fluid resuscitation to restore blood volume and circulatory function, and if necessary, vasopressors support medications to maintain blood pressure. It's about stabilizing the patient's entire physiology while you combat the infection.
Given the global rise in antibiotic resistance, how does that factor into choosing the right antibiotics in those critical first moments? That must add a layer of complexity.
It's a huge consideration. Clinicians must actively think about the increased prevalence of antibiotic resistance, even in bacteria acquired outside of hospitals, so-called community-acquired bacteria. You need broad-spectrum coverage initially to hit the likely culprits while you wait for definitive culture results and susceptibility testing.
Okay.
And another crucial point, often overlooked perhaps, is that pharmacodynamics, how the drug moves through and acts on the body, are altered in sepsis.
How so?
Patients in septic shock often have an increased volume of distribution. The drug spreads out more within their body because of leaky capillaries and fluid shifts, and they might also have increased renal clearance, meaning their kidneys might eliminate the drug faster than usual, at least initially.
So you need to adjust the dose.
Yes. Adequate antimicrobial dosing is absolutely crucial to ensure the drug reaches therapeutic levels in the tissues and effectively kills the pathogen. Underdosing can be just as detrimental as delaying treatment altogether. You need to hit hard and fast. Hashtag B. The role of urgent surgical intervention when the knife is as key as the drug.
This might surprise some listeners, but for many infections, the solution isn't just a drug. Our sources make it clear that for several infections, urgent surgical attention is as important as, or even more important than, antibiotic therapy. Why is surgery so vital in these cases?
That's a vital distinction. Infections involving localized collections of pus, or importantly, necrotic tissue, dead tissue, or those causing compression of vital structures, often require immediate source control that only surgery can provide. Antibiotics alone can't penetrate dead tissue or large pus collections effectively.
Can you give some specific examples?
Sure. Neurosurgical evaluation is critical for conditions like subdural empyema, which is that collection of pus between the brain and its outer membrane. Otolaryngologic surgery, that's ear, nose, and throat, is needed urgently for possible mucormycosis, a rapidly invasive fungal infection that can destroy facial tissues. And cardiothoracic surgery is essential for critically ill patients with acute endocarditis, where infections on heart valves can rapidly lead to heart failure or send infected clots throughout the body.
So the antibiotics can't do their job if the source of the problem, the pus, the dead tissue, the infected valve, isn't removed or drained. It's like trying to put out a fire when the fuel source is still present.
Exactly. And for certain infections, rapid surgical intervention literally supersedes other diagnostic or therapeutic maneuvers. It's the #1 priority.
Like which ones?
For instance, in cases of necrotizing fasciitis, the so-called flesh-eating bacterial infection, or Clostridial myonecrosis, often known as gas gangrene, the immediate removal of all dead and infected tissue is paramount. Without it, the infection will progress relentlessly, regardless of how many antibiotics you administer. Surgery is life-saving, often more so than the initial antibiotic choice in those specific situations. Hashtag tag see adjunctive therapies and important cautions, fine-tuning the response.
Beyond antibiotics and surgery, are there other treatments that can significantly impact outcomes, sort of like specialized support teams coming in?
Yes, adjunctive treatments, given alongside the primary therapies, can often reduce morbidity and mortality rates. A key example highlighted in the sources is dexamethasone, a type of steroid for bacterial meningitis.
We mentioned that timing was critical.
Absolutely crucial. It must be given before or at the time of the first dose of antibiotic for improved outcomes in adults, particularly with pneumococcal meningitis. It helps reduce the inflammation caused by the bacterial breakdown products.
Okay. Any others?
Another one is intravenous immunoglobulin, or IVIG. This can be beneficial for toxic shock syndrome. It contains antibodies that can help neutralize the toxins produced by the bacteria.
So these are like a powerful boost to the main treatment. But there's a crucial caveat here, right? Not all adjunctive therapies are universally beneficial, and some can even be harmful depending on the situation. It's not a one-size-fits-all approach.
Precisely. This really highlights the nuance required in these urgent situations. While glucocorticoids like dexamethasone can be beneficial in certain contexts, like bacterial meningitis, they can also be potentially harmful in other specific settings,
Such as?
such as cerebral malaria or certain types of viral hepatitis. In these cases, their immunosuppressive effects or metabolic impacts could actually worsen the patient's condition. It's a fine-tuning process that requires a deep understanding of the specific pathogen, the host's response, and the evidence behind each intervention.
Now let's pivot to a truly game-changing area, genomics. This isn't just about identifying a bacteria, it's about understanding its entire blueprint, its DNA, and it's fundamentally transforming how we approach infectious diseases. It's like having a master key to the enemy's intelligence files.
Genomic technologies are truly revolutionizing many aspects of medicine, and yeah, their impact in infectious diseases is profound. The core idea is that by looking at the genetic information of pathogens, we gain unprecedented insights into their identity, their weaknesses, how they spread, and how they evolve.
Give us an example of this revolution in action. What can genomics do that traditional methods can't or can't do nearly as quickly?
Well, one powerful example is the ability to quickly detect antibiotic resistance. Take rifampin resistance in Mycobacterium tuberculosis, the bacteria causing TB.
Right.
Traditional culture methods can take weeks to identify resistance patterns. That's critical time lost when dealing with a highly contagious and dangerous pathogen. But with genomic methods, we can detect the genetic mutations conferring rifampin resistance, which often signals multi-drug resistant tuberculosis in mere hours.
Hours versus weeks. That's huge.
It's massive. It can immediately guide therapy and public health interventions without needing complex culture infrastructure right away.
That speed must be invaluable. And it goes beyond individual patient diagnosis, doesn't it? It helps see the bigger picture of outbreaks.
What's truly fascinating here is how genomics has revolutionized epidemic tracking. High-resolution genomic tracking of the spread of diseases, think cholera, Ebola, Zika, and most recently COVID-19, has yielded incredible insights. We can see how a virus is moving, mutating, which public health measures are actually working to slow it down.
Like mapping the spread in real time.
Almost. For example, during the early months of the COVID-19 pandemic, an astounding 55,000 viral genome sequences were reported globally within just the first 6 months. This rapid sharing of data allowed for a global, nearly real-time understanding of the virus's spread and evolution.
So it's about real-time, global mapping of disease, almost predicting its next move.
Yes, and these genomic tracking efforts often involve close collaborations with local scientists and public health officials right on the ground. There's been significant investment in sequencing infrastructure, particularly in places like sub-Saharan Africa, which has made this kind of on-location epidemic tracking feasible.
Building capacity where it's needed most.
Exactly. This kind of investment not only enables real-time outbreak recognition and tracking, but also provides the infrastructure to capitalize on many other benefits of high-throughput sequencing as the technology continues to develop. And the accessibility and synergy are increasing too. Sequencing efforts are getting cheaper and moving closer to the point of care every year. As these technologies link up with global information technology resources, it promises to spread state-of-the-art tools for diagnosis, treatment, and epidemic tracking to the areas that need them most.
The COVID-19 pandemic, in particular, really served as a compelling demonstration of the central role that genomic tools now play. It showed the world what genomics could truly do at an unprecedented speed, almost like a real-time scientific sprint.
Without a doubt, the rapid discovery of SARS-CoV-2 and the sequencing of its entire genome that was completed within weeks of the clinical syndrome's recognition, an astonishing feat.
Weeks is incredible.
And the rapid public sharing of this genome sequence led directly to two key interventions crucial in the global response. First, the development of diagnostic assays like RT-qPCR, which became the backbone of testing.
Right, the PCR test.
And perhaps most importantly, accelerated vaccine design.
How did that genomic information speed up vaccine development so dramatically? What was the shortcut?
Crucially, vaccine development was informed by the homology, the genetic similarity of the SARS-CoV-2 sequence to previously studied coronaviruses, specifically SARS and MERS. The dominant antigen of those viruses, the surface protein known as the spike protein, was already well characterized from that earlier research.
So we had a head start because of previous work.
A massive head start. This existing knowledge, combined with the quickly shared SARS-CoV-2 genome, allowed the design of the first SARS-CoV-2 vaccines to begin literally the day after the genome sequence was publicly shared.
The day after. Wow.
This rapid leap from discovery to design, culminating in the most rapidly developed and validated vaccines in human history, was unquestionably accelerated by genomic technology.
That's truly remarkable, turning a deadly unknown into a solvable problem so quickly. And genomics continued to play a big role after the initial discovery and vaccine design too, right? Tracking the virus as it changed.
Yes, whole genome sequencing, or WGS, played a large and ongoing role throughout the pandemic. It was vital for outbreak tracking, confirming case clusters in places like hospitals or nursing homes.
Pinpointing where it was spreading.
Exactly. It also helped distinguish true reinfections from recrudescence, meaning a flare-up of the original infection or just prolonged viral shedding, which has implications for isolation periods. WGS was also crucial in monitoring the virus's spread through societies and, critically, in tracking pathogen evolution.
The variants.
Right, including the emergence of new variants of concern. These variants often exhibited altered transmissibility, different severity, or partial evasion of the immune response from prior infections, vaccines, or monoclonal antibody treatments. Genomics allowed us to spot them and understand them quickly.
And it even helped us understand why people responded so differently to the virus. You know, from mild cases to severe ones.
Exactly. Cutting-edge genomic methods, including things like single-cell transcriptional profiling and genome-wide association studies, GWS, contributed significantly to understanding that wide variability in SARS-CoV-2 infection outcomes. Why did some people get so sick while others were asymptomatic? Genomics helped scientists pinpoint host genetic factors influencing disease severity.
Fascinating.
Overall, the global response to COVID-19 undeniably underscored the indispensable role genomics now plays in clinical and public health management of infectious diseases. But, the devastating impact also revealed the urgent need for further development and implementation of these tools for disease surveillance and response, particularly in low-resource settings. We saw the gaps. #TAC. The broader impact and future outlook for genomics. What does this all mean?
So, looking beyond COVID-19, what does this all mean for the broader impact and future outlook for genomics in infectious diseases? It sounds like we're on the cusp of a new era, but maybe one with its own set of challenges.
We definitely are, but it's a journey. The core idea is that genomics technologies are fundamentally transforming infectious disease medicine. But yeah, there are still significant challenges. These methods, next-generation sequencing, genome-scale expression analysis, they're dramatically expanding our understanding of microorganism interactions.
How so?
We can see how microbes interact with each other in complex communities, like the gut microbiome, how they interact with their human hosts at a molecular level, how they interact with the environment. This kind of holistic view is unprecedented.
So we're not just looking at a single pathogen in isolation, but its entire ecosystem, its context. What's holding back even wider adoption of these powerful tools, making them routine everywhere?
Despite these incredible advancements, there are still significant technological and, frankly, financial barriers slowing widespread adoption of large-scale pathogen sequencing in routine clinical and public health settings. It's still expensive and complex.
What needs to happen to overcome that?
Future requirements are pretty immense.
Yeah.
We need innovations in data storage. We're generating vast amounts of data. We need development of sophisticated bioinformatics tools to manipulate and interpret that data effectively. Standardization of methods across different labs is crucial for consistency. And, critically, comprehensive training of end users, the clinicians, the lab techs, the public health officials in both research and clinical realms. The human element, the expertise, is key.
And is the cost effectiveness clear yet? Does using these advanced methods truly save money or lives in the long run, beyond the initial investment? Is the value proposition solid?
That's a crucial question, and the honest answer is it's still being studied. The cost-effectiveness and applicability of whole genome sequencing, particularly right there in the clinic for individual patient care, still need to be rigorously evaluated. Furthermore, studies looking directly at its impact on patient outcomes, does it lead to better survival, faster recovery, are crucial to clarify where these new methodologies can make the greatest contributions. This research is ongoing and absolutely vital to justify broader implementation.
But despite these hurdles, the overall outlook remains optimistic. We're still moving towards a future where clinicians are even better equipped.
Absolutely. The ongoing efforts to overcome these limitations through collaboration, teaching, and reduction of financial obstacles are highly commendable and need to be expanded. With continued advances in genomic technologies and computational analysis, our ability to detect, characterize, treat, monitor, prevent, and control infections has advanced rapidly in recent years and will continue to do so. The hope, the real promise, is that this heralds a new era where the clinician is better armed than ever before to combat infection and promote human health. We're moving closer to a future where we can truly master infectious diseases.
Okay, now that we've laid the groundwork understanding the critical first moments, the rapid diagnostics, the treatment principles, and the revolutionary role of genomics, let's truly dive deeper. We'll explore a few specific infectious disease emergencies that vividly illustrate these principles in action. Think of these as case studies revealing the unique challenges faced by those elite professionals we talked about. Hashtag tag asepsis. Without a clear focus, unmasking hidden threats.
Yeah, many patients presenting with severe infection, especially septic shock, that life-threatening condition caused by the body's overwhelming response to infection, they initially have non-specific symptoms. There's no obvious primary site of infection, like pneumonia or a UTI.
So it's harder to know where to target treatment initially.
Exactly. It's common and presents a significant diagnostic challenge. The usual culprits behind this are organisms like Pseudomonas species, various gram-negative enteric bacilli gut bacteria, basically Staphylococcus species, and Streptococcus species, including MRSA.
And certain patient groups are at higher risk here.
Definitely.
Yeah.
Certain groups face particularly increased risk for an adverse outcome. Elderly patients who might have atypical presentations, making it harder to recognize sepsis early. Immunocompromised hosts may be due to malignancy and neutropenia, and patients who have recently undergone surgery or hospitalization are also at higher risk.
And the risk of delayed treatment or hitting the bug with the wrong drug because of resistance, that seems like a recurring nightmare scenario in sepsis.
It is. Outcomes are significantly worse when antimicrobial treatment is delayed, or when the pathogen ultimately proves not susceptible to the initial empirical regimen you chose. The increasing prevalence of multi-drug-resistant organisms makes this especially relevant today.
So that initial broad-spectrum choice is critical.
It is. Broad-spectrum antimicrobial agents are recommended and should be instituted rapidly, ideally within the first hour after recognizing septic shock. It's also important to consider that the incidence of fungal septic shock is increasing. And in endemic areas, you have to think about non-bacterial causes of shock, like dengue virus infection, because mortality can increase if it goes undiagnosed.
What about those biomarkers like C-reactive protein or procalcitonin? Do they help pinpoint things early?
They can be useful later on, maybe for de-escalation, meaning narrowing down the antibiotic therapy once you have more information, or deciding when to stop antibiotics. But for the initial diagnosis or prognosis of sepsis, they haven't proved consistently reliable on their own. Clinical assessment remains key.
Earlier, you mentioned lack of splenic function as a host factor. Can you elaborate on why asplenic patients, those without a spleen, are at such high risk for overwhelming infection? What threats do they face specifically?
This is a really critical area for clinicians to be aware of. The spleen plays a vital role in filtering blood and fighting certain types of bacteria,
Mm,
particularly those encapsulated bacteria we mentioned: Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitis.
the ones with the protective shells.
Right. Patients without splenic function, whether from surgery or a congenital condition, are at a severely heightened risk for overwhelming bacterial sepsis from these organisms. It can be incredibly rapid and fatal.
How high is the risk?
Splenic adults, for example, succumb to sepsis at something like 58 times the rate of the general population. It's a huge increase. And while most infections occur within the first year or two post-splenectomy, the increased risk persists throughout their entire life. The median time between splenectomy and sepsis is actually quite long, maybe 4 to 6 years, but it ranges from 1 year up to 19 years or more. S. pneumonia is the most common culprit, causing 40% to 70% of these overwhelming infections.
So it's a lifelong vulnerability. And speaking of under-recognized but serious threats, babesiosis comes to mind. What makes this tick-borne disease so dangerous, especially for these vulnerable patients?
Yeah, babesiosis is another important one, especially with changing tick distributions. It's tick-borne, so a history of recent travel to endemic areas like parts of the Northeast and Midwest U.S. should raise suspicion. Typically, 1 to 4 weeks after a tick bite, the patient experiences flu-like symptoms: fever, chills, fatigue, muscle aches.
That's pretty generic.
It does, which makes it tricky. And the same tick, Ixodes scapularis, also transmits Lyme disease and anaplasmosis, so co-infection can occur, and that often results in more severe disease.
Okay.
Crucially, while Babesia microti is the more common species in the U.S. and often causes milder illness, the European species, Babesia divergens, is far more frequently fulminant, meaning severe and rapid. It causes a severe febrile syndrome with dramatic hemolysis, that's destruction of red blood cells, jaundice, and acute renal failure. It's associated with a mortality rate exceeding 40%.
Over 40%.
Yeah. And severe babesiosis is especially common in asplenic hosts or those who are immunosuppressed for other reasons. Again, highlighting how understanding those host factors can literally be life-saving for conditions like this.
And there are other rare but really high mortality threats lurking out there too, right? Like tularemia and plague.
Yes, though thankfully rare, they are severe. Tularemia, particularly the typhoidal form, which presents like sepsis without obvious localized signs, has a mortality rate over 30% if untreated. Plague, especially the septicemic form, also carries around a 30% mortality rate even with treatment. These have specific epidemiological contexts: exposure to rabbits or rodents for tularemia, fleas from infected rodents for plague, and are also classified by the CDC as potential bioterrorism agents, adding another layer of concern. Hashtag BSepsis with skin manifestations when the skin tells a story.
Now let's turn to when the skin literally tells a story. Sepsis with distinct skin manifestations can provide crucial, immediate diagnostic clues, almost like the pathogen is leaving its signature right there for you to see.
Absolutely. Meningococcemia caused by Neisseria meningitis is a prime example. Nearly 3/4 of patients with this bacterial bloodstream infection develop a rash.
What does it look like?
It initially appears as pink, blanching maculopapular lesions, basically flat pink spots that turn white when you press them. But then it rapidly progresses to hemorrhagic petechiae, those small, pinpoint red or purple spots that don't blanch. These often start on the ankles, wrists, and in the armpits, then spread.
Okay, so the non-blanching spots are key.
Very key. And in its rapidly progressive form, which happens in 10% to 20% of cases, the rash quickly becomes purpuric, larger, bruised-looking lesions, and patients develop disseminated intravascular coagulation, or DIC.
With the clotting disorder we mentioned.
Right, where blood clots form throughout the small vessels, leading to organ damage and paradoxically bleeding elsewhere. This progresses rapidly to multi-organ failure and shock, with mortality rates historically between 50% and 60% in this severe form. This is where early antibiotic initiation, sometimes even before hospital admission by paramedics, can be life-saving, and it underscores the vital role of vaccination against meningococcus.
What about Rocky Mountain spotted fever? It also has a distinctive rash that's often talked about but maybe misunderstood. I hear it doesn't always show up.
Yes, RMSF is another critical one, caused by Rickettsia rickettsii and transmitted by ticks. For the first 3 days or so, patients usually just have flu-like symptoms: fever, headache, muscle aches. By day 3, about half develop skin findings. Typically, blanching macules appear on the wrists and ankles, then spread. These lesions often become hemorrhagic and petechial later on.
Does it spread to the palms and soles? I remember hearing that's classic.
It frequently does spread to the palms and soles later in the course, and a centripetal spread from extremities inward to the trunk is considered classic, but it actually occurs in a minority of patients. Even more importantly, and this is crucial for diagnosis, 10% to 15% of patients with confirmed RMSF never develop a rash at all.
No rash at all. That makes it incredibly hard to diagnose early.
Extremely challenging, and delay is dangerous. Untreated, RMSF has mortality rates ranging from 20% to 30%. Severe complications include non-cardiogenic pulmonary edema and encephalitis. Timely recognition based on clinical suspicion and epidemiological clues, and prompt treatment with doxycycline, a tetracycline antibiotic, are crucial for survival. There are other related rickettsial diseases too, like Mediterranean spotted fever, epidemic typhus, scrub typhus. They also respond well to tetracyclines if caught early.
Then there's purpura fulminans. That sounds ominous just from the name.
It is. Purpura fulminans isn't a specific infection itself, but rather the cutaneous manifestation, the skin sign of severe DIC, often seen in overwhelming sepsis. Patients develop large ecchymotic areas, like extensive bruises, sometimes with hemorrhagic bullae or blisters. This rapidly progresses to gangrene of the extremities and is associated with severe organ failure and death.
What causes it most often?
It's primarily associated with Neisseria meningitis infection, but it can also occur in splenectomized patients infected with S. pneumonia, H. influenza, or even Staphylococcus aureus. It's a sign of catastrophic systemic failure.
And ecthyma gangrenosum. That's another specific skin lesion linked to a particular bug, right?
Yes, ecthyma gangrenosum is quite specific. It describes these characteristic skin lesions. They start as vesicles or pustules, often hemorrhagic, which then ulcerate and develop a central area of black necrosis surrounded by redness. It's considered almost pathognomonic, meaning highly characteristic, of Pseudomonas aeruginosa septic shock, particularly in immunocompromised patients, like those with neutropenia. Seeing that lesion should immediately trigger treatment covering Pseudomonas.
Hey, any other notable rash-associated infections we should cover? Ones that signal serious trouble.
Definitely. Vibrio vulnificus infection is one. This occurs typically after eating contaminated raw shellfish, especially oysters, or sometimes through wound exposure to seawater. It's particularly dangerous for patients with chronic liver disease or iron overload states. They can develop rapidly progressive septic shock with characteristic bullous, often hemorrhagic, skin lesions, particularly on the lower extremities. The mortality rate can be up to 60%. It's incredibly high.
Oysters and liver disease, a deadly combination there potentially.
Potentially, yes. Another one is Capnocytophaga canamorsis infection. This bacterium is found in the mouths of dogs and cats. Infection typically follows a dog bite, though sometimes just close contact is enough. While often harmless in healthy people, it can cause overwhelming septic shock in asplenic or cirrhotic patients. The mortality rate is around 30%, and complications like DIC and gangrene requiring amputation can occur. It's another reason why animal bites in susceptible individuals need prompt attention.
Wow. Okay, let's switch gears slightly within skin signs. What about toxic shock syndrome, TSS? That's a term many people have heard, often associated with a diffuse rash.
It is. Erythroderma toxic shock syndrome, TSS, is usually associated with erythroderma, that sunburn-type rash we mentioned, which can be subtle or diffuse and sometimes peels later on. Patients present with fever, malaise, muscle aches, and then rapid development of hypotension, often within hours. Multi-organ failure is common.
Is there anything that helps distinguish it early on?
One key feature is that early renal failure may actually precede the drop in blood pressure, which helps distinguish it from some other septic shock syndromes where hypotension comes first.
Interesting. And there are different types.
Yes, broadly speaking, staphylococcal TSS, often associated with mucosal colonization, maybe from tampon use historically or wound infections where the rash might be subtle. And streptococcal TSS, which is more often associated with a clear skin or soft tissue infection focus, like necrotizing fasciitis, and patients are more likely to be bacteremic, have bacteria in the blood. Strep TSS generally has higher mortality rates, maybe 50–70%. There are also rare, highly fatal forms linked to Clostridium sordellii, particularly in obstetric settings.
What helps treat TSS specifically?
Besides aggressive supportive care and antibiotics targeting the underlying bacteria, therapies aimed at toxin production or neutralization are important. Clindamycin, an antibiotic that suppresses toxin production, is often added. And 5-immunoglobulin, IVGUI, can provide antibodies to neutralize the circulating toxins and has shown benefit, especially in severe strep TSS.
Lastly, in this category, the viral hemorrhagic fevers. These sound terrifying and often make headlines.
They are serious. These are generally zoonotic illnesses transmitted from animals to humans caused by viruses like Lassa, Ebola, Marburg, dengue, yellow fever, and hantavirus, causing hemorrhagic fever with renal syndrome, HFRS. They typically start with a prodrome of fever and muscle aches.
Like many other infections.
Right, nonspecific initially, but then they progress to cause vascular damage, leading to increased capillary permeability, bleeding manifestations like petechia or bruising, shock, and often neurologic signs. Dengue hemorrhagic fever causes over 12,000 deaths annually worldwide. And the Ebola outbreak in West Africa in 2014 had mortality rates exceeding 50%. Travel history and potential exposures are absolutely key to considering these diagnoses early. #see sepsis with soft tissue muscle, primary focus, the hidden destruction.
Moving on to another critical area, sepsis, where the primary focus is deep in the soft tissues and muscles. These infections can be deceptively hidden at first but cause rapid, massive destruction, turning what seems like a minor injury into a major catastrophe.
Absolutely. Necrotizing fasciitis is a terrifying example. This infection is characterized by extensive necrosis tissue death of the subcutaneous tissue and the fascia, which are the layers of connective tissue beneath the skin and around muscles. It can arise from minimal trauma, like a small cut or even a bruise, or follow a surgical incision, but it can also complicate recent chickenpox, childbirth, or even just a muscle strain.
And the initial presentation can be dangerously misleading, right? The pain seems way out of proportion to what you see.
Yes, deceptively so. Initially, the physical findings might be minimal compared to the severity of pain and fever the patient reports. The infected area might just appear as soft tissue swelling and redness, maybe hot, shiny, swollen, and exquisitely tender to touch. But then, it progresses rapidly. Within maybe 36 hours, the overlying skin can develop ominous blue-gray patches. Then cutaneous large blisters, often filled with dark fluid, appear, followed by frank skin necrosis within 3 to 5 days.
And you mentioned earlier there's a very counterintuitive sign with the pain.
Yes, a truly ominous sign is when the intense pain actually starts to decrease. This isn't because the patient is getting better, it's because the infection has destroyed the superficial nerves in the area. Anesthesia develops.
So, less pain means more danger.
Yeah.
A truly terrifying indicator. What are the outcomes for this, and what's the absolute crucial intervention?
The mortality rate is very high, anywhere from 15% to 34% overall in modern series. It can be over 70% if it's associated with streptococcal toxic shock syndrome, and it's nearly 100% fatal without surgical intervention. This highlights the critical point we made earlier. With rapid aggressive surgery to debride, meaning remove all the dead and infected tissue, outcomes improve significantly. Mortality can be reduced to less than 40% even in the setting of TSS if surgery is prompt. This is a classic example where the knife is as key as the drug, maybe even more so initially. Common culprits include group A streptococcus, but also Clostridium perfringens and sometimes community-associated MRSA, CA-MRSA.
Another devastating condition in this category is clostridial myonecrosis, often known as gas gangrene. How does this compare to necrotizing fasciitis? It sounds even faster.
It is an even more rapidly progressing and highly fatal soft tissue infection. Myonecrosis involves necrosis primarily of the muscle tissue itself. It's often associated with significant trauma, especially crush injuries or surgery, but it can also develop spontaneously, particularly in patients with underlying conditions like diabetes or malignancy.
How fast does it move?
The incubation period is usually short, maybe 12 to 24 hours after injury or onset, and then massive necrotizing gangrene develops within hours. Systemic toxicity, shock, and death can occur within a staggering 12 hours of the first symptoms appearing if untreated.
12 hours, that's terrifyingly fast.
It is. Again, the patient's pain and toxic appearance are often way out of proportion to the initial physical findings. They might be febrile, confused, have a very rapid heart rate and breathing rate, and sometimes express a profound feeling of impending doom.
What does the skin look like?
The skin over the affected muscle area becomes tense, pale, then develops a characteristic bronze-brown discoloration. It can be mottled and edematous. Bullous lesions filled with reddish-brown or bloody drainage can develop, and sometimes a distinctive mousy or sweet odor is present due to bacterial metabolism. Crepitus, that crackling sensation under the skin from gas bubbles, occurs relatively late in clostridial myonecrosis because the gas is primarily deep within the muscle tissue initially. Like necrotizing fasciitis, this is an absolute surgical emergency where rapid radical debridement is paramount for survival. Mortality rates remain very high, especially for spontaneous forms, often exceeding 65%. Hashtag tag tag D. Neurologic infections with or without septic shock, the brain under attack.
Now we delve into when the brain itself is under attack. Neurologic infections are common infectious disease emergencies, and they can have profound, permanent consequences, making rapid diagnosis and treatment absolutely vital. The stakes feel incredibly high here.
They absolutely are. Bacterial meningitis is a prime example an infection of the meninges, the membrane surrounding the brain and spinal cord. Most adult cases are due to Streptococcus pneumonia and Neisseria meningitidis, though Listeria monocytogenes is an important consideration, especially for immunocompromised patients, pregnant women, and the elderly.
What's a classic presentation people might think of?
The classic triad is fever, meningismus, neck stiffness, and headache, and altered mental status. However, this full triad is seen in only about half to two-thirds of patients and maybe even less than half of elderly adults. So relying only on the classic signs can lead to misdiagnoses.
So you have to have a high index of suspicion. What are other signs?
Cerebral dysfunction is common, evidenced by confusion, delirium, lethargy that can progress to coma. Seizures can occur. Some cases are truly fulminant, with rapid onset of sepsis, shock, and significant brain edema.
And prognosis can be very poor if not treated quickly, highlighting the urgency of the approach we've been discussing.
Indeed. Poor prognostic indicators include things like coma on presentation, seizures, hypotension, shock, and specific findings in the cerebrospinal fluid analysis, like very low glucose or very high protein. The critical importance of rapid treatment cannot be overstated. Studies suggest the odds of an unfavorable outcome, like death or severe neurologic disability, may increase by as much as 30% for each hour that effective antibiotic treatment is delayed.
That really drives home the time is brain concept here, too.
Absolutely. And as we mentioned, dexamethasone, the steroid, is a crucial adjunctive treatment for bacterial meningitis in adults, especially for suspected or confirmed pneumococcal cases. But again, that timing is critical. It must be given before or with the first dose of antibiotics to improve outcomes by reducing harmful inflammation.
What about other suppurative intracranial infections, those involving actual pus collections within the skull? These sound like truly dire emergencies.
They are. These conditions include things like subdural empyema, pus between the dura and arachnoid membranes, septic cavernous sinus thrombosis, infected clot in a major venous sinus at the base of the skull, often from facial infections, and septic thrombosis of the superior sagittal sinus, infected clot in the large vein running along the top of the brain. These often present alongside sepsis and hemodynamic instability. Rapid recognition of the toxic patient with central neurologic signs like focal weakness, seizures, vision problems, cranial nerve palsies is crucial.
Where do these usually come from?
They typically arise as complications of other localized infections. Paranasal sinusitis is a common source for subdural empyema and sagittal sinus thrombosis. Facial or dental infections can lead to cavernous sinus thrombosis. Common pathogens include streptococci, staphylococci, and anaerobes. These conditions require critical, rapid neurosurgical consultation for potential drainage, alongside broad-spectrum antibiotic therapy that penetrates the blood-brain barrier well. Survival and reduction of permanent deficits depend heavily on prompt intervention.
And a brain abscess. I imagine that's also often a surgical emergency.
Often, yes, though the presentation can be different. A brain abscess frequently occurs without systemic signs like high fever or sepsis. Almost half of patients are actually a febrile at presentation. The symptoms are more often consistent with a space-occupying lesion within the brain.
Like a tumor might present.
Exactly. Patients often experience headache, altered mental status, seizures, and/or focal neurologic signs depending on the abscess location. They can be single or multiple. They can result from continuous spread from nearby infections like chronic sinusitis, ear infections, or dental infections, or from hematogenous spread bacteria traveling through the bloodstream, perhaps from endocarditis or lung infections.
How does an abscess form?
It typically progresses from an initial stage of localized brain inflammation, called cerebritis, to a fully formed, encapsulated abscess over several days to weeks. The etiology is often polymicrobial, involving a mix of bacteria. Abscesses arising from hematogenous spread are particularly dangerous because they are often multiple and have a higher risk of rupturing into the brain's ventricular system, causing sudden, severe deterioration and a very high mortality rate. Again, immediate neuroimaging, usually CT with contrast or MRI, and neurosurgical consultation are critical elements of the approach, along with prolonged antibiotic therapy.
What about cerebral malaria? That's a huge global health issue and a concern for travelers returning from or residents of endemic areas. How does that present?
It's an urgent consideration. Any febrile patient with neurologic changes who has been in a malaria endemic area needs to be evaluated for this. Fulminant malaria, caused by Plasmodium falciparum, can present with very high temperatures, hypotension, jaundice. By definition, any patient with P. falciparum infection who develops a change in mental status, confusion, lethargy, coma, or repeated seizures has cerebral malaria.
How quickly does it progress?
In adults, this often starts as a nonspecific febrile illness, but progresses to coma over several days, sometimes even hours. If unrecognized or untreated, it can lead to death within 24 hours. The overall mortality rate, even with treatment, is around 15–20%, and it's particularly devastating in children who are at high risk for long-term neurologic and mental health sequelae even if they survive. And crucially, as we noted, glucocorticoids should generally be avoided in cerebral malaria, as studies have shown they can worsen outcomes. This highlights again the need for precise, evidence-based treatment for each specific condition.
And briefly, intracranial and spinal epidural abscesses. These are infections in the space around the brain or spinal cord lining.
Yes, ICAs and Cs. Key risk factors include things like diabetes, IV drug use, recent spinal trauma or surgery, or other sources of bloodstream infection. ICAs often present with fever, mental status changes, and neck pain, while CAs classically cause fever, localized spinal tenderness, and progressive back pain that can lead to neurologic deficits like weakness or paralysis if the spinal cord is compressed. Early diagnosis with MRI and prompt treatment, which often includes surgical drainage along with antibiotics, are crucial to minimize mortality and prevent permanent neurologic damage. #tag E. Other focal syndromes with a fulminant course systemic impact from localized sites.
Finally, let's touch on other focal syndromes that might seem localized at first glance but can have a devastating fulminant systemic impact, demanding urgent coordinated action. Sometimes the trouble starts small but spreads fast.
Exactly. These are critical to recognize because a seemingly contained infection can rapidly become life-threatening. One such condition is Lemaire's syndrome. This is relatively rare but severe. It's characterized by jugular septic thrombophlebitis, essentially an infected blood clot in the internal jugular vein in the neck, typically following an oropharyngeal infection like tonsillitis or pharyngitis.
What causes it?
It's caused primarily by an anaerobic bacterium called Fusobacterium necrophorum. The infected clot can then break off and send metastatic infectious emboli fragments containing bacteria throughout the body, predominantly to the lungs,
Right.
causing septic pulmonary emboli, lung abscesses, or empyema. But emboli can also go to joints, liver, or other organs, resulting in widespread sepsis.
What's prognosis?
Even with antibiotics, the mortality rate reported is still over 15% in some series. Interestingly, Fusobacterium bloodstream infections have also been associated with underlying, sometimes occult, gastrointestinal or genitourinary malignancy, so finding it can be an important red flag for other conditions too.
And rhinocerebral mucormycosis sounds incredibly aggressive, almost like something out of a horror film, the way it spreads.
It is terrifyingly aggressive. This invasive fungal infection carries a very high risk, primarily for patients with uncontrolled diabetes, especially diabetic ketoacidosis, or other immunocompromising conditions like hematologic malignancies or solid organ transplant recipients.
How does it present? What are the signs?
Patients often present with a distinctive set of symptoms, maybe low-grade fever, dull sinus pain, facial swelling or pain, sometimes double vision or decreased eye movement if the infection spreads into the orbit. A critical finding on examination is the presence of dusky or frankly necrotic black tissue on the nasal turbinates or the hard palate, often sharply respecting the midline.
So black tissue inside the nose or mouth.
Yes, that's a hallmark sign. Without rapid recognition, aggressive surgical debridement of all infected tissue, and prompt initiation of specific antifungal therapy like amphotericin B, this fungal process follows an inexorable invasive course spreading rapidly into the sinuses, eyes, and brain. The mortality rates remain extremely high, ranging from 50% to 85% or even greater, depending on the extent of disease and the underlying host condition. It's a true race against time involving medical and surgical teams.
Acute bacterial endocarditis can also go from 0 to critical very quickly, especially impacting the heart itself. How does that differ from more slowly developing forms?
Yes, acute bacterial endocarditis, often caused by virulent organisms like Staphylococcus aureus, presents with a much more aggressive and rapidly progressive course compared to subacute forms typically caused by less virulent streptococci. Patients often present acutely ill with fever, fatigue, malaise, maybe new heart murmurs.
What are the major dangers?
The bacteria can rapidly attack and destroy native heart valves, particularly the aortic or mitral valves. This rapid valvular destruction can lead directly to acute, severe heart failure with pulmonary edema and hypotension. Severe complications also include the formation of myocardial abscesses, collections of pus within the heart muscle itself, which can disrupt the heart's electrical conduction system, leading to life-threatening arrhythmias and major arterial emboli, where fragments of the infected vegetation break off and travel to the brain, causing stroke, limbs, or other organs. Rapid diagnosis, often involving echocardiography and prompt intervention with appropriate antibiotics and often urgent cardiac surgery, are absolutely crucial for a successful outcome, especially as older patients or those with SORIAS endocarditis may present with nonspecific symptoms, delaying diagnosis.
And then inhalational anthrax, which we sadly became refamiliar with during the bioterrorism events in 2001, a truly terrifying example of a rapidly progressing infection after exposure.
Indeed, inhalational anthrax, caused by inhaling spores of Bacillus anthracis, is the most severe form of the disease. Historically extremely rare in the U.S. before 2001, the cases then highlighted its rapid progression. Patients initially presented with nonspecific prodromal symptoms lasting a few days, things like malaise, fever, nonproductive cough, drenching sweats, and shortness of breath.
What were the key diagnostic clues?
Critically, all patients in the 2001 outbreak had abnormal chest X-rays at presentation, even during the prodromal phase. Characteristic findings included pulmonary infiltrates, mediastinal widening, that classic sign where the space between the lungs looks enlarged due to massive hemorrhagic lymph node swelling, and pleural effusions, fluid around the lungs. Survival was significantly more likely when appropriate antibiotics like ciprofloxacin and or doxycycline were started during that early prodromal period and when multi-drug regimens were used. In the absence of urgent intervention with effective antimicrobial agents and aggressive supportive care, inhalational anthrax progresses rapidly over hours to days to fulminant sepsis, respiratory failure, hemorrhagic meningitis, shock, cyanosis, and death.
Finally, the severe respiratory viral illnesses, which have certainly been top of mind for all of us in recent years. They demonstrate just how quickly a respiratory virus can turn fatal, overwhelming the lungs and body.
Yes, this group includes agents like avian influenza, like H5N1, and swine influenza, like the 2009 H1N1 pandemic strain, SARS, severe acute respiratory syndrome coronavirus, COVID-19, caused by SARS-CoV-2, MERS, Middle East respiratory syndrome coronavirus, and hantavirus pulmonary syndrome, caused by Guillain-Barré virus and related viruses in the Americas. These viruses can all cause severe respiratory illness, often with rapid progression within days to acute respiratory distress syndrome, ARDS, that severe lung injury where fluid fills the air sacs, requiring mechanical ventilation and often leading to multi-organ failure and shock.
So for patients presenting with severe respiratory illness, especially with relevant exposures,
Absolutely. For patients presenting with severe pneumonia or ARDS, especially with a relevant exposure history, like poultry exposure for avian flu, travel to the Middle East for MERS, rodent exposure for hantavirus, or during known outbreaks, these possibilities must always be considered early. Appropriate infection control measures must be instituted immediately to protect healthcare workers and other patients, alongside aggressive supportive care, including careful fluid management and respiratory support.
and of course COVID-19 has been the most impactful and devastating recent example of this type of viral respiratory emergency on a global scale.
The COVID-19 pandemic has been a historic global public health crisis. As we discussed with genomics, SARS-CoV-2 primarily transmits person to person via respiratory droplets. While about 80% of symptomatic patients had mild disease, around 15% developed severe disease requiring oxygen, and about 5% became critically ill, often developing respiratory failure, shock, and multi-organ system failure.
What was the typical timeline?
Patients typically experience symptoms like fever, cough, fatigue, loss of taste smell for about 5 to 7 days before potentially progressing to severe pneumonia and hypoxemia. Shock, when it occurred, was often associated with direct cardiac injury or myocarditis. Arrhythmias were common, and thromboembolic complications like pulmonary emboli and stroke were alarmingly frequent.
What did the lab tests show?
Common lab findings included lymphopenia, low lymphocyte count, elevated inflammatory markers like LDH, CRP, D-dimer, and ferritin, sometimes suggesting a cytokine release type syndrome. Chest imaging typically showed diffuse ground glass opacities, consolidation, and sometimes effusions.
And treatment evolved rapidly.
It did. Current approaches include supportive care, oxygen, ventilation, specific antiviral therapy like remdesivir or Paxlovid early on, and importantly, anti-inflammatory therapy. Notably, dexamethasone or other glucocorticoids were clearly shown in large trials to reduce 28-day mortality in patients requiring oxygen or ventilation. Anticoagulation prophylaxis or treatment also became standard due to the high clot risk. Early on, there was also a focus on delaying invasive mechanical ventilation if possible, using non-invasive strategies, because lung mechanics often remained relatively preserved despite severe hypoxemia. But ultimately, prevention through highly effective vaccines proved to be the most important strategy to control the pandemic's devastating impact, underscoring that critical blend of clinical care and public health strategy.
And just briefly mentioning the other viruses in this category.
Right. Avian swine influenza can cause rapid progression to AIRS, often linked to specific exposures. SARS, the first novel coronavirus pandemic threat in 2003, showed efficient human transmission, but was controlled by classic public health measures like isolation. MERS has inefficient human-to-human transmission, often linked to camel contact, but carries a very high mortality rate, requiring strict infection control. And hantavirus pulmonary syndrome, linked to rodent exposure in the Americas, is characterized by abrupt onset of respiratory failure and shock, due largely to myocardial depression and leaky capillaries. Careful fluid resuscitation is key, and early thrombocytopenia, low platelets, can be a distinguishing feature.
And finally, we must mention Clostridioids difficile infection, or CDI. Not always presenting as septic shock initially, but certainly a major threat, especially in healthcare settings.
Yes, absolutely. CDI is primarily a toxin-mediated diarrheal syndrome, though severe forms can lead to toxic megacolon, bowel perforation, and sepsis. It's strongly associated with prior antibiotic use, which disrupts the normal gut flora, allowing C. difficile to overgrow, and also with proton pump inhibitors. While traditionally linked to healthcare settings, community-onset CDI is definitely increasing. It causes significant morbidity and mortality, particularly among older or debilitated patients. The CDC has recognized C. difficile infection as one of the top 3 urgent health threats associated with antibiotic use in the U.S., underscoring its significant public health burden and the challenge it presents in managing acutely ill patients, often complicating their recovery from other conditions. #outro.
Wow. What an incredible deep dive. We've just navigated the immense complexity, the sheer speed, and the critical importance of the immediate, accurate, and multifaceted responses required for acutely ill febrile patients. It's really staggering.
It is.
From that perceptive physician's initial glance, through the diagnostic maze, the treatment decisions, right up to the cutting edge of genomics, we've tried to arm you, our listeners, with insights akin to what elite professionals in this field utilize every single day, hopefully giving you a kind of mastery-level understanding of this critical medical approach.
Yeah, it's a field defined by urgency and precision. Every decision, from that initial observation to the choice of the right therapy at the right time, carries profound implications. Understanding these pathways isn't just academic. It's about appreciating the heroic effort behind every successful outcome and the constant evolution of medical science in this incredibly high-stakes environment.
Absolutely. And as we consider these rapid advancements, particularly in genomics, alongside the persistent, evolving threat of infectious pathogens that we've discussed today, it raises an important question for all of us, doesn't it? What responsibility do we, as informed individuals, have in understanding and supporting the infrastructure necessary for global health security? Beyond just the clinical response in the hospital, how can we apply the critical thinking and rapid information assimilation skills we've exercised today to better discerning health information, filtering out the noise, and maybe supporting crucial public health initiatives in our own communities and daily lives?
That's a great point. It really extends beyond the clinic walls.
It's definitely a thought to really mull over as we all ultimately play a part in promoting public health and being prepared for these kinds of challenges.